The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar topic today is Management of Recurrent Meningioma. My name is Umbreen Maan, Program Manager here at the ABTA, and I'm delighted to introduce our speaker. Dr. Gelareh Zadeh is Dan Family Chair and Professor of Neurosurgery at the University of Toronto. She has a dedicated neuro-oncology and skull-based practice, which includes a number of multidisciplinary specialized programs, including a skull-based clinic, brain metastases, pituitary clinic, and neurofibromatosis clinic. She has an active research laboratory focused on integrated multi-platform molecular analysis of brain tumors, together with a focus on understanding molecular response to targeted therapies. Thank you for joining us, Dr. Zadeh. You may now begin your presentation. It looks like you're muted.
That's right. Thank you, Umbreen, for the invitation and the introduction. Thank you to the American Brain Tumor Association for hosting these series, and of course to all of the members who have logged into the session. I could see over 88 people that are on right now. So it's an interesting topic to discuss. It's an area of my focus, and both clinical and research. And I hope some of the material that I share with you allows this dialogue at the end of the session. I have no disclosures nor conflicts, and the granting agencies that support the work that I do in the lab are listed as below. And of course, recognizing once again the American Brain Tumor Association for their support of research, but also more importantly for patient advocacy. The learning objectives for the session are to learn about the incidence of recurrent meningiomas, standard and novel treatment strategies for recurrent meningiomas, and the long-term effects of recurrent meningioma on quality of life, and how to manage symptoms and side effects. The slide will not necessarily follow this order, but the rationale in which I'd like to present the data that we have to you. I do also want to acknowledge my lab. We have a diverse group of expertise, interests, and members from varied backgrounds that have done a lot of the work that I show you, and it's a team that I'm proud of being able to work with. So going to the incidence and recurrence of meningiomas, I have to say upfront that the true incidence of recurrent meningiomas is not known, and that is an area that needs to require additional research. In general, meningiomas are an extremely understudied tumor type, and in particular, the epidemiology, the risk factors, and the contributing biological factors to its formation and growth are continually being explored and being better understood. If we look at the brain tumors that we deal with on a day-to-day basis, of the 150 that the World Health Organization lists in the diagnosis of brain tumors, there's really a handful that we manage on a day-to-day basis. And if we look at the various brain tumors that we deal with as neurosurgeons, neuro-oncologists in our practice, there has been significant progress in some of the tumor types, whereas others still fall behind in understanding the biology and treatment. So for example, here, and hopefully you can see my cursor, this is a pituitary macroadenoma, a giant tumor that is benign. It's a surgical tumor, and the advance for this tumor has been entirely surgical in that we are now able to resect this tumor completely endoscopically, avoid opening the brain and doing an open craniotomy. And as a consequence, we're able to remove this tumor. The optic nerves that are compressed by the tumor have been decompressed, and the patient's vision is restored. This is an extremely gratifying experience for myself to be able to help the patient, and the outcomes are generally positive and requires no additional treatment after surgical resection. Another area that has benefited from advances in innovation and technology, and our approach to it as a consequence has changed significantly, are vestibular schwannomas, or referred to as acoustic neuromas. These are benign tumors that arise from the 8th cranial nerve that allows us to hear and gives us balance. And traditionally, these were operated on through open surgery. But with the advent of adopting and accepting the innovation in technology called Gamma Knife, which is a format of giving radiation, focused radiation to the tumor, you could see in this image that the individual has a frame on their head where it's converting through these points that you see on the side an individual's brain into a 3D axis and allows us to do target-focused radiation therapy for the tumor. And this has been a huge revolution and shift in how we manage acoustic schwannomas, because we only really reserve surgery to those tumors that are greater than 3 to 3.5 centimeters, resulting in about 80% being treated in a non-invasive manner. The other tumors that we deal with on a very frequent basis are meningiomas, which are the pictures that you see here, and gliomas. Majority of the understanding of our research focus is on gliomas in the field of neuro-oncology. And I would like to subject and propose that we change that and shift it towards focusing on advances in meningiomas. And why is that? Because if we look at the statistics of brain tumors, if you look at all brain tumors, and these slides are the courtesy of the CB Trust that produces the incidence per year of brain tumors. If we look at all of brain tumors per year, you could see that in fact, a significant portion, a larger part of the pie compared to any other tumor is meningiomas. The incidence of meningiomas is in fact higher than glioblastoma, which is the most commonly recognized malignant brain cancer. If we remove the malignant subtypes, the brain cancers, from this mix and look at those that are typically classified under benign, but I would again propose that this is not necessarily the appropriate way of looking at them as a benign tumor, you could see that more than 50% of brain tumors that we deal with are meningiomas. And they can occur anywhere in the brain. They can be very well defined, as you could see here. Again, hopefully my cursor shows it. They could be large, but still very well defined. They can be extremely aggressive, as you see in the image below, where it involves neurovascular structures, so cranial nerves, neuronal tissue, vasculature that goes to the brain becomes highly engaged with the tumor. And this actually results in partial resection in order to be able to protect and preserve the function of the brain, protect the vasculature, and so residual tumor is left behind in cases where the tumor is quite complex. If we look at the incidence of brain tumors again, all of the various brain tumors that I showed you that we commonly manage on a day-to-day basis, they have a drop-off in their incidence in the mid-60s, whereas meningiomas increase in incidence in mid-60s. If we also look at the map of the world to see whether the population is aging, in fact, you could see by 2015, the projection for those that are over 60 increases significantly across the globe, in particular in North America. Healthcare is such that we expect people's longevity and life expectancy to go higher. And for all of us who manage meningiomas and brain tumors in general, we see that there is an increasing number of patients who present with meningiomas at older age. And this poses a new area and challenge in how to manage patients who have meningiomas at an older age, where previously we may have perhaps said no to surgery. And what are the decision-making factors? And so it's a tumor that really demands for us as a field to focus on, to better understand the biology of it, to better understand the therapeutic opportunities for it, and most importantly, the impact on individuals. In general, it's thought that the incidence of meningiomas, and unfortunately we don't have the accurate statistics on this, nor the recurrence, is about 1.85 per 100,000 of the population. So if you look at it compared to common cancers such as breast, prostate, melanoma, the incidence is much lower, but as I showed you, it is one of the largest percentage of brain tumors that we deal with. Majority of patients who have meningiomas come to attention through local focal deficits, which is a focal neurological sign, arm weakness, leg weakness, difficulty with speech. They, on occasion, present with headaches and ICP, raised ICP symptoms, and seizures is a big component of the neurological symptoms of a meningioma. On imaging, particularly, you could see, as I said, well-defined, well-circumscribed tumors, and you could often see that there's some associated swelling around the lesion, and potentially there could be some evidence of bleeding within the tumor or invasion of the brain, and I'll show you examples of that. If we see an individual who's had a workup for any of these symptoms or has had an MRI for other reasons, workup of cancer, workup for headaches or other, and the tumor is identified, majority of these tumors, in fact, stay stable and require only surveillance imaging. There are, however, a significant percentage that go on to growth and progression, such as this one, where the size of the tumor increases, the engagement of the normal neurological and bony structure. In this instance, you could see that the bone around the tumor has in fact overgrown, resulting in an additional consideration for surgery. You could see that the tumor progresses. And at the time of presentation, we currently have no way of predicting who will progress and who will remain stable. And so we need to do better at identifying the rate of progression for an individual tumor. And similarly, that goes for identifying patients who would have a recurrence after surgical resection, and I'll show you data related to that. What are the treatment options? In general, when you look at brain tumors, the treatment options are rather linear and well-defined. The current paradigms that we follow is that the individual receives a diagnosis after an MRI is done. Either they were symptomatic or, as I said, they had an MRI for another reason and an incidental tumor was identified. And as a consequence, the patient then either goes on to having surveillance MRI and routine follow-up every 3, 6 annual follow-up MRI. And we only intervene if the tumor progresses and grows and therefore requires surgical resection. And then following surgical resection, in the cases of a glial tumor, we are given some molecular information. In the case of meningiomas, until very recently, where the WHO categorization of tumors incorporated some molecular features for meningiomas, no molecular features were required. After that, the patient then goes on to either have continued surveillance. If there are features of concern, and we'll review those, the patient either goes on to radiation. For meningiomas, chemotherapy options are very limited. And in the instance that it fails, there is consideration for clinical trials, and hopefully I could show you some of the existing clinical trials that are ongoing for meningiomas. So where I think we've made a difference is here with introduction of molecular knowledge to change the decision-making on what happens after surgical resection. And that really focuses on the prediction and the ability to determine whether a meningioma is going to be recurrent or not. So majority of the meningiomas, these are dissections from brain sections with meningiomas. You can draw a line around them. They're well-defined, well-circumscribed. They have a nice plane. And as a surgeon, a task of resection of this tumor becomes relatively straightforward. There are, however, meningiomas that you could see you cannot draw a very clear-cut line around the borders of the tumor and brain. There's significant invasion of the brain. There's significant invasion of the bone. And in this case, you could see on the histological section that there is, in fact, finger projections of the tumor, much like roots of a plant, into the normal brain. And sometimes you can see crests of tumor cells, islands of tumor cells that are invaded far beyond the actual tumor. And this, of course, makes the tumor quite aggressive because surgically, though we can remove the bulk of the tumor, the area where these finger projections occur, as surgeons, we're limited in how far we can chase and follow all of these regions. And some of it is not actually visible to us, even under the microscope. So how do we actually identify an aggressive meningioma from a benign tumor, a benign meningioma? Majority of the meningiomas are considered to be benign because they have that well-defined, well-circumscribed border that allows us as surgeons to go around the whole tumor and remove it completely. Those are predominantly our grade 1 meningiomas. And this is the most recent 2021 updated grading of meningiomas for WHO classification, the World Health Organization. If we look under the microscope, there's 18 different subtypes of meningiomas. These 18 different subtypes are defined based on their appearance under the microscope, and they are somewhat aesthetically pleasing. However, rarely do they reflect whether the tumor is going to be aggressive or not. And you could see here in this panel that 9 of the different subtypes are, in fact, grade 1 meningiomas with no features of concern. Where does it become a grade 2? A tumor that has more aggressive features. Mitotic figure is the rate by which the cells are dividing. And if a pathologist looks under the microscope per high power field, so if they go on high magnification and they see 4 to 19 mitotic figures in 10 different regions of the tumor, they would call this a grade 2. As you can imagine, there's a significant variability in calling this 4 to 19 mitotic figures between one and the other pathologist, because it also depends on a number of factors. What portion of the tumor we as the surgeons submitted to neuropathology, because not all of the tumor goes to neuropathology, and also what region under the microscope they look at the 10 consecutive high power fields. And there's good data to show that there's variability between neuropathology to be able to call the mitotic figure. Or it's an unequivocal brain invasion, like I showed you, the finger projection, the islands of tumor cells that sit within normal brain, or they have one of these specific appearances under the microscope, atypical, clear cell, and chordoid. This is really based on experience of the eye of the pathologist that they can call these various subtypes. Or they have one of the following 3 features: increased cellularity, so very dense tumor. They have small cells with a high nuclear to cytoplasmic ratio, prominent nucleoli, sheeting, and foci of spontaneous necrosis. These are some perhaps more specific content jargon relative to or relevant to the neuropathologist, but you could see that the grading is somewhat still very much dependent on the observation of the neuropathologist. Grade 3 are tumors that are either anaplastic, papillary, or rhabdoid. They have higher mitotic figure compared to grade 2, or they have frank aneuplosia, which is they have necrosis, or they have a TERT promoter mutation, which is the new genetic changes that we look in tumors, or they have a deletion of the CDKN2A and or CDKN2B. These 2 new features written in red are what's been added to the World Health Organization, recognizing the value of the molecular analysis that's been done on meningiomas. And so if somebody had an operation a few years before having this grading introduced, maybe it would be valuable to go back and look at the molecular features of the tumor to determine the aggressiveness and to ensure that these do not exist in the tumor, that would then speak of a higher recurrence rate. The recurrence rate of grade 3 is thought to be 100%, with the longevity limited to less than 18 months. The grade 2 has a higher recurrence rate than grade 1, and grade 1 is thought that if we resect completely, there would be no recurrence. However, I'll show you some data that then questions perhaps our understanding of that is limited. What does a complete recurrence look like? In the world of surgery, for the work that I do and my colleagues in neuro-oncology, we very much rely on Symptom grading. It was a grading that was introduced many decades ago based on CT scans, so currently this would not be the standard that we use, but the extent of resection grading that you see here actually is what we use in day-to-day practice still, because it's relevant. You're either considered to have gross total resection or subtotal resection. Gross total resection is when we can completely remove everything, including the covering of the brain and the bone that's perhaps invaded and overgrown. If there is a grade 2 resection, there could be some tumor left along the dura, the covering of the brain, but the surgeon is able to coagulate that tumor with the thought that the coagulation, the burning of the cells, prevents them from dividing and further growing and having a recurrence. Or grade 3 gross total resection is that we've coagulated the dura, but there are parts of it that perhaps we could not access by surgery. Or there's hyperostosis, there's overgrowth of bone that we were not able to drill. Subtotal resection, of course, as expected, is partial resection of a tumor, and 5 is those tumors that we can only really biopsy because of its location is in such a complex region that we can't access by surgery. Ambreen, I'm going to stop and just ask you, because I see that there are some questions. If anybody wants to stop me or yourself, please feel free to do so. So I mentioned to you that typically it's thought that grade 1 benign tumors have a complete resection and no recurrence. Grade 2 have a higher propensity for recurrence, and grade 3 have nearly 100%. But if you look at our own institutional data, we could see that all the grade 1s have a very wide range of recurrence. And in fact, it's not correct that all grade 1s that have been fully resected, this is the recurrence in meningiomas that have been fully resected, have a 0 recurrence rate. In fact, the majority of our meningiomas have grade 1 diagnosis. The rate of recurrence is 4%, and there is a residual in these tumors. In grade 2, you can also see there's a wide recurrence rate. The incidence of grade 2 meningiomas at our institution is about 20%. The rate of recurrence is 22%, much higher than grade 1. And then grade 3 meningiomas, the incidence is smaller. It's about 2%, which is generally the range in which we see grade 3. But it is not correct that they have 100% recurrence. And for those of us that manage meningiomas with high volumes, we all have within our practice grade 3 meningiomas that we were able to resect completely, and in fact there is no recurrence for that individual. So there is a portion of patients that have no recurrence associated with a grade 3, and that's important in decision making, because if your tumor behaves well, though given a grade 3 assignment, you may be able to avoid additional treatment, and that's the population we need to identify. What is the half of the population that will actually not have a recurrence if you have a grade 3 meningioma? So how do we manage recurrence of meningiomas? We first want to look at really the treatments and side effects associated with them. As I mentioned at the start of the talk, because research and understanding on meningiomas has been limited until very recently, the guidelines that are available and the data that we rely on in clinical decision-making is very limited. The most recent guideline from EANO, the European Association of Neuro-Oncology, a group of my colleagues that are very well versed in this area and are very well experienced in producing guidelines, have the following guidelines for meningiomas. Level A evidence, good data to support what is recommended in regards to seizure management for patients with meningiomas, because as we mentioned, that is the highest symptom associated with a meningioma. They do not recommend seizure medication if the patient has not had seizures. So anti-epileptics are not recommended preoperatively, intraoperatively, or after surgery if a patient does not have seizures. I will, however, mention to you that it is in our practice that if during surgery we find that the brain is very inflamed, is irritated, the tumor is engaged with the brain, not necessarily invaded, but engaged, wrapped around structures, that from experience, providing anti-epileptics during surgery perhaps helps control seizures after surgery. But that said, we don't have data to prove that. Level C evidence that is not as definitive data available in the literature, but again, based on our collective experience and review of literature, we can say that patients who've never had a seizure, it's insufficient evidence to recommend anti-epileptics to reduce the risk of seizure occurrence. There's insufficient evidence to prescribe valproic acid or levetiracetam, which is both anti-seizure medications, to potentially decrease growth of the tumor and increase overall survival, because there is some studies to suggest that. And there's insufficient evidence to support using the subtype of the tumor, the grade of the tumor, the location of the tumor, and whether or not there's molecular features associated with it to start anti-epileptic seizures. So for patients who have seizures, the recommendation is to start anti-epileptics, and currently our preferred anti-epileptic is Keppra. And in our practice, we tend to use Keppra. It's a drug that's better tolerated. The clearance of it is easier by the patient, and the side effects of it is less than other traditional anti-epileptic medication. So what are the factors associated with preoperative seizures in meningiomas? It's again a very vague area. The studies are somewhat limited due to the numbers of each study being variable. So some have 20 patients in the study, some have hundreds. So if you look at this table, if we look at the total number of publications on this subject, the number of patients in each study varies from 32 to 180 to as small as 11 to as high as 225. So naturally, there will be a variability in the report of the percentages of patients that have seizures associated with this. So you could see that the percentage ranges from 0.6, very low, to as high as approximately 22%. So nevertheless, when we look at these studies and the meta-analysis done by Dr. McDermott and his colleagues, shows that there are some associations. Not all studies show that there is a male to female preponderance, but 3 of the studies show that there is such a preponderance where male versus female makes a difference in incidence of seizures. Whether or not the patient has headaches, only one study really finds a significance. And whether the location is skull-based versus non-skull-based, I would say that in my experience, whether the patient has a posterior fossa meningioma in the skull base, the rate of seizure is lower. I would also say that in these studies, the interpretation is limited because where we define the skull base could be within the anterior region and the posterior fossa, but the anterior region, in fact, comes in contact with our normal brain more so than the posterior fossa, and so the likelihood of seizures is higher. The other study has looked at whether there's genetic factors. So I showed you that in the World Health Organization, some of the molecular features are what we use now to define aggressive behavior of tumors. And they looked at whether preoperatively or postoperatively, these genetic factors may have in fact contributed to patients having seizures. So blue is yes and red is no. And of all the known genetic aberrations in meningiomas, it appears that if there's an NF2 aberration, mutation or other, that there is a higher risk of seizure associated with the patient. And when we look at multivariate, looking at all the factors that contribute to this, you could think of this as a algorithm that if you have an NF2 mutated subgroup of patients, they have a higher chance of perioperative seizure, in particular if their histology is atypical, there's swelling that we could see on the MRI, and there's evidence of brain invasion. So these are, again, some factors that come into consideration when deciding to start anti-seizure medication or not for patients that were diagnosed with meningiomas. The next area after surgical resection, of course, is radiation therapy. In particular for grade 2, majority of centers will recommend radiation therapy after resection. For grade 3, almost all centers would recommend radiation therapy after resection. And although radiation therapy has very good long-term survival and control of tumor recurrence, it appears that if we look at the quality of life questionnaire and information related to health-related quality of life, that in fact there are toxicities associated with radiation. And so this is why it's important that when we select for patients to go on for radiation therapy, that we do so with absolute certainty that they benefit from radiation to avoid the long-term consequences of radiation and the toxicities associated with it. So if we again look at all of the patients who have had radiotherapy for WHO grade 2 and WHO grade 3, which are the ones that typically receive radiation in the form of fractionated radiation, there is good control rate, variable again between 50 to 86. The reason there's this variability in literature is because the study numbers are smaller and variable from one center to another. And especially, you could see that for grade 3 meningiomas, the range of 5-year control is less than 50%. But although we are able to have some degree of positive results with radiation control, there is a fair degree of radiation side effects. So radiation necrosis, which is the reaction of the brain, the normal brain typically, and tumor to radiation injury, is quoted between 6 to 27%, so a significant range. And in particular, in pediatric population, when given radiation at an early age, long-term, it's thought that it causes vascular events, meaning strokes or TIA type events. So all factors that need to be considered when making a decision in management for individuals with meningiomas. I mentioned to you that vestibular schwannomas have had a transformation in their care by introduction of gamma knife radiosurgery, because the radiation can be targeted very tightly to the lesion itself, avoiding radiation to the normal brain. And so there has been an interest to try and optimize and prioritize using gamma knife radiosurgery for meningiomas as well, to avoid the radiation injury to the brain. However, when we look at the literature of radiosurgery, gamma knife, the focus radiation to the lesions, whether it's a residual meningioma, a meningioma that cannot be resected by surgery, or a recurrent meningioma where the volume is small, again, less than 3 centimeters, you could see that the complications associated with gamma knife radiosurgery, once again, is around 25%. So it's not without complication. In the largest study, which is by one of my, our very well recognized group in the world of gamma knife radiosurgery, is from Pittsburgh, Dr. Lunsford, Dr. Konzioka. You could see that they studied approximately 1,000 patients, and the adverse events associated with gamma knife radiosurgery, again, is not insignificant, 6 to 16%. So although necessary for some patients to receive radiation, I would suggest that perhaps there are mechanisms that we can identify patients who may not need radiation, and therefore we can avoid radiation and the toxic effects that come as a consequence of radiation therapy. How do we do that? So I showed you WHO classification based on histology, what the pathologist looks under the microscope, and they can grade it between 1, 2, and 3. However, the factors that distinguish a grade 2 from 1 and grade 3 from grade 2 and grade 1 are somewhat subjective based on the mitotic figure, the proliferation rate, which can be variable from neuropathologist to neuropathologist. Most recently, there's introduction of the TERT promoter mutation and the CDKN2A mutation, but that's extremely recent, only in the last few months, and we have to see whether it stands the test of time. An area that we've worked on significantly is to look at methylation. And this, we believe, overrides grading based on WHO classification, and also overrides grading based on Symptom, the extent of resection. We analyzed a large cohort of meningiomas from 2 different institutions to validate our results. We used a training set based on the University of Toronto cohort and validated based on MD Anderson cohort, 2 large size of meningiomas. We looked at all grade meningiomas, so grade 1, 2, and 3. We looked at a variable rate of extent of resection based on gender, based on age, all of these factors considered. We could see that methylation analysis divides the tumors into 2 distinct groups. And this 2 distinct groups, independent of any other factors that I've mentioned, show that in fact the outcome of the patient is very different. Blue has a very favorable outcome, red has an unfavorable outcome. So independent of the factors that are known. At the same time we did this study, our colleagues in Heidelberg, the DKFZ German Cancer Center, did a similar study, and they found that methylation, again, independent of any other factor, divides the tumors into 6 groups. I would say that the first 3 are the benign, the favorable outcome group that we have, an intermediate group, which are the 2 in between, and then the malignant group, which is the unfavorable outcome. So again, data that validated and supported what we had done, which is to show that there are two distinct categories of methylation for meningiomas. What does that mean for an individual patient? Because if you look at these graphs, whether my tumor falls on this end of the graph or whether it falls on the better outcome part of the graph is not known. We need to individualize the methylation results for that patient. I won't go through the details of the technical aspects of how we did this, but we are able to take an individual meningioma, analyze its methylation signature, and use that signature to give a predictive score for outcome for the individual. So if you look at all meningiomas, grade 1, grade 2, and grade 3, grade 1 are always considered to be benign, but I showed you that that's not always the case. There is a 5% chance of recurrence for grade 1 meningiomas. Grade 2 are thought to be intermediate, but again, there is a subset of them that do well in our clinical practice and a subset that do very poorly. And then grade 3 are considered to be the worst outcome meningiomas, but in our practice, there's about a 50% who don't have recurrence. And in fact, that 50% could avoid upfront radiation to avoid the toxicities. This is based on WHO classification. If you take the same cohort of tumors and analyze them with methylation that I presented to you just a few slides ago, you could see that it also divides the tumors into 3 categories. However, these are independent of WHO grade. So if you look at all WHO grade 1, what's considered to be benign meningiomas, methylation shows that majority of them are in fact benign and behave well. But there is a subset that we need to be aware of. We're given the assignment of grade 1, but methylation tells us that they will behave aggressively. In WHO grade 2, that are the intermediate group, there is a subset of them that do very well. So I would say, and we have implemented this now based on our data at our institution, that if you have a grade 2 meningioma where your methylation shows that you're going to do well, we avoid giving radiation. There's a subset by comparison that actually do very poorly, and so they will need more aggressive upfront treatment. The grade 3 meningiomas, I showed you our institutional data, 50% have no recurrence rate, despite what is thought to be a very aggressive tumor. And you could see that majority of the grade 3 meningiomas, in fact, do poorly, but there is a subset that do very well. And again, I would propose that this subset could avoid radiation and could be continued to monitor closely with surveillance MRI. We converted all of this data into a calculator. The calculator has 100 points. The methylation score weighs 100%. So we analyze the tumor of the individual patient by methylation. We include the WHO grade, but the weight of the WHO grade in this calculator is about 50%. We also integrate the Symptom grading of extent of resection that I showed you, which weighs in about 20%. So in a hypothetical situation where the WHO grade is 2, the extent of resection is grade 3 Symptom grade. The methylation score is about 60% based on our algorithm that we use. The total score comes to about 90. On the calculator, this translates to a 0.4 or a 60% recurrence rate in 5 years. So independent of the grade or the extent of resection, we can calculate an additional value that tells you your likelihood of recurrence. So I'm going to show you 2 examples of how we can use this score effectively, and it has stood the test of time since we've introduced this score, and it's now implemented at our institution, and we perform methylation for our patients across Canada and internationally. So this is an individual who has a meningioma. It was relatively well circumscribed. However, it did have finger projections where the surgeon was unable to fully resect this tumor. The grade of the tumor by histopathology, traditional pathology, was 2. Extent of resection was 4, since there was some residual left. The methylome score is 0.89. This is what we calculate in the lab based on methylation. The 5-year prediction for recurrence of this tumor is 0.09, which is the inverse of this number, the likelihood that it would come back in 5 years. and that number is quite high. And you could see that in 33 months, this individual has had a significant recurrence. Similar type patient, similar tumor, has a good resection. However, there's again finger projections because of the invasion. It's the same tumor as last case, grade 2, extent of resection 4, with the difference that the methylation score is much lower. The inverse of this is a much higher number. And 72 months later, this individual has had no recurrence. And so right now, we use this methylation score for our patients to be able to predict aggressiveness of the tumor, and as a result, be able to tailor whether or not we give an individual radiation. So both these cases have grade 2 meningiomas. However, not both of them require radiation. So the first case with an aggressive recurrence, we would give radiation. For the second case, this tumor, where there is no recurrence, we would withhold radiation until there is radiographic MR imaging results that show progression. This data was published. It was published in 2019. And as I mentioned, we've implemented that in our practice. I might actually just very quickly go through the range of clinical trials that we can summarize to see in meningiomas, are there effective clinical trials that have taken an intervention, a drug, a therapy, and shown that there is impact on the patients to the point that it changes our practice. And I would say, unfortunately, not. But there's a wealth of clinical trials that allow us, whether it's positive or negative, because I think a negative outcome is also very useful for us to say that, for example, a drug such as pastiritide, which has historically been thought to control meningiomas, does not in fact control progression-free survival. So we can move away from potentially exploring this or thinking of subtypes of meningiomas that this drug may be beneficial to meningiomas. Another drug that's been trialed is the adhesion kinase inhibitors, and this is relevant for NF2 mutated tumors. And it shows that the patients can tolerate this. This is a phase 2 clinical trial. The jury and verdict is out whether or not, in fact, in a phase 3, it would demonstrate that there is improvement in outcome. Other phase 2 clinical trials you could see here, Nivo, which is a drug that's becoming very popular for its impact on potentially immune therapeutic and cell cycle effects. And you could see that, in fact, again, there are some studies that show it's well tolerated, so patients can actually be exposed to it. That's the first step in being able to go on to the next phase, which is a phase 3 trial. And in fact, it can be tolerated by the patients. Similarly, if we look at a phase 2 trial of Pembro, there is evidence that maybe some patients don't tolerate this drug. It has some side effects that does not allow the patients to continue. But the primary endpoint, which is a progression-free survival increase, was met and achieved. And so some promise that perhaps this can go on to a phase 3 trial. By comparison, there are other phase 2 trials that show perhaps that the progression-free survival was not increased when tested in a phase 2 for grade 2 and 3 meningiomas. There's a wide range of other phase 2 trials that you could see here, and the results are variable. Some do show that the progression-free survival is increased. Some show that it has no impact. And I think the summary of these clinical trials is not necessarily to be disappointed, but it does tell us that not one meningioma is the same as the other meningioma. And we need to understand better the molecular features of a meningioma and which of the subtypes of meningioma is going to respond to the therapeutic that we're subjecting the patient to. So these slides will be available for review and sharing. Then some of them are clinical trials that are ongoing and open. I want to leave time for questions, so I don't want to go through all of them in specific and in detail, but certainly for you to refer to see what clinical trials are available. The clinical trials that are in phase 3 predominantly are around the fact whether radiation therapy is needed for all meningiomas. I showed you the methylation data we have that suggests perhaps very strongly, based on methylation, you can make decisions on whether or not to give radiation. But these are the ongoing trials, both in the US and Europe, where they're looking at the question of the value of adding radiation therapy to grade 2 and grade 3 meningiomas. I'd like to wrap up by a study that we had done some time ago through the ABTA and their support to look at something which is very important for me, the impact on patients' quality of life experience and symptoms. What's interesting that came out of the survey, which is the data I had always thought was the case from my experience in managing patients with meningiomas, is that the symptoms that patients present with, and this is based on approximately 1,800 people who responded before treatment, you could see that the range of symptoms are headache, weakness in an arm or leg, trouble coordinating, seizures, loss of cognitive ability, trouble with vision, difficulty hearing, behavioral changes, fatigue. Some were unsure of their symptoms and other. Majority of the symptoms after surgical resection actually persist. In the world of neuro-oncology, when the tumor is completely resected, it is felt that perhaps the patient is cured. But what's most important is to see whether these symptoms persist, because we cannot say that we've achieved complete cure or a complete response if the symptoms persist. In particular, a symptom that in fact increased after surgical resection was fatigued. And when we tease out fatigue, it's really the sense of brain fog and the inability to bring everything together to be able to get to the place where they were at baseline before their diagnosis. And data to confirm that is from the patients we ask, are you able to get back to your career, to your work, to your vocation, your school, or preoperative state? And you could see that, in fact, majority of people cannot. And those that have a significant amount that are unable to get back are in the more elderly age population. So very important data that I think we need to focus on. There's an absolute need for us, in addition to looking at therapeutic strategies, and most importantly, to understand symptoms. And in order for us to be able to understand symptoms and synthesize what's been said to us in a survey, where 35% of the patients feel that perhaps important, adequate information was not shared with them, and that the symptoms, in fact, persisted. Fatigue is the one that increased after surgery. We need to understand better how this contributes to the patient's quality of life, and more importantly, why it is that the symptoms persist. A very well-known factor is that we are able to capture information in real time on a continuous basis, and this has been shown in many different cancer types, not for brain cancer, that in fact a control helps manage the anxiety that comes with symptoms associated with disease. And so in line with that, we'd like to be able to introduce mechanisms and measures and do a study where we track patients' experiences, symptoms, and their psychological symptoms, their functional symptoms and limitations, to be able to then target areas that we need to focus on for research. And in order to do that, I think we know that a majority of us have a mobile phone, and apps are a key feature in accessing information. And we have introduced in a very beta form an app that can actually capture my story, can capture all of the symptoms, help manage some of the symptoms, for example, frequency of headaches, frequency of fatigue, the duration, the period in the day where you feel fatigue-associated symptoms, and gives a wealth of information to your healthcare provider to be able to then target, based on each visit, areas that we'd like to focus on addressing. So perhaps, Ambreen, with this, I'll stop here because I do think it's important for us to have some time to field questions. And again, I really want to thank you and the audience for the opportunity. I'm going to stop sharing my slides.
Great. Thank you so much for that presentation. We do have lots of wonderful questions, so we will jump right in. Just as a reminder for anyone, if you do have a question that you'd like to ask, please type and submit it using the Q&A button on the bottom of your screen, and we'll answer questions as time allows. So one of the first questions we have here is asking, are meningiomas hereditary? You talked a lot about molecular analysis, different genetic components. Is it possible for a meningioma to be hereditary? Is there any research on that?
Yeah, so a very good question. Majority of meningiomas are sporadic. However, there are some genetic conditions, such as neurofibromatosis, that has a propensity for meningioma formation, and I think that would be one category. The other is that there are some genetic mutations that could be hereditary, very rare, but you would require that family history to have concern for that. But majority of meningiomas are not hereditary.
Thank you so much for clarifying that. You talked about the methylation signature and how this can be an important tool. Do you know how long this has been used as a tool in brain tumor treatment centers? Is it something that is readily available to any patient in the US? Would they have to make a special request for this type of analysis?
So that's an excellent practical question. Methylation as a classifier to make sure that the diagnosis is accurate has been in place for approximately 4 to 5 years. There are a number of centers, very select, that do methylation. We're one of them at University of Toronto. The NIH is another center in North America, NYU, New York University, and then the DKFZ in Germany, London, England. There's few centers that do methylation, but the positive is that it's readily doable for an individual to send their tumor histology, the block, the sample from the pathology lab, and the methylation can be done at any of the labs that I mentioned to you.
Thank you so much.
The methylation predictor that I showed you, sorry, Amberine, the predictor that I showed you that determines your recurrence risk for meningiomas, it's something that we've developed in our program, and it's actually a software that's made available publicly. We're able to give you the predictive score based on methylation. So either the sample is sent to us, methylation analysis is done, or methylation analysis is done at one of the other labs, and they send that information to us, and then we are able to calculate a 5-year recurrence score. And we've done this for a number of individuals now.
That's great. Thank you so much. Can you explain the difference between tumor growth and reoccurrence for a patient who's on surveillance? How can you tell the difference between whether it is tumor growth or an actual reoccurrence?
Yeah, so again, an excellent question. The language, and you may have picked this up in the literature or if you see physicians, the language is not unified. So generally you have a residual if some of the tumor is left behind. That residual can grow and progress, and so that's considered a regrowth or recurrence. But then it becomes vague if they completely remove the tumor and the tumor comes back, whether in fact there was no tumor left behind or simply that the surgeon was unable to see regions where the brain had tumor involvement. The bottom line is that the distinction is more academic based on understanding tumor biology. The practicality of it is that there is a tumor that has now come back, whether there was some residual that was not obvious to the naked eye of the surgeon resecting it completely, or whether there were some areas that had tumor involvement that was not visible and now is continuing to grow. And so the distinction there doesn't really make a significant clinical impact. I think the distinction really comes from that methylation signature as to whether it's more aggressive or not. I hope I explained my answer sufficiently for this individual.
Yes, that was great. Thank you so much. Now, when we're talking about reoccurrence, how likely is it that the grade level will change? A patient who originally had a grade 1 that was removed, is it possible for it to reoccur at a different grade level, and vice versa? If it was higher, can they have a reoccurrence with a lower grade?
Yes, again, very good question. If you look at large series, the likelihood of a tumor coming back as a higher grade is less than 10%. It could certainly happen. It's rare that it goes from 1 to 2. It can go from 2 to 3 in a higher likelihood. But again, we don't have the accurate incidences and numbers on these. But when we look at larger scale data, which we have tried to collect through the consortium that I've introduced, we have an international consortium on meningiomas. that tries to tackle some of these key important questions. And we see that within institutions, there are 39 institutions now that are part of the international consortium. The rate is less than 10%. There is an evolution to a higher grade.
Thank you so much for clarifying that. Another question we have here is asking about whether or not endoscopic surgery is something that is possible for meningiomas, and are there any particular factors about maybe tumor size or tumor location that might make endoscopic removal more likely or not?
Great. I would say that the meningiomas that are most suitable for endoscopic resection are those that occur in the anterior skull base. So if you can see me on the screen, it's anything that is between the midline of our eyes, the middle of our eyes, extending back by approximately 5 to 6 centimeters. That's the region we can access endoscopically. There are some surgeons at some institutions where they do an open surgical resection, and in corners where perhaps we're unable to visualize the tumor, we could see that there is some tumor residual if an endoscope is placed. That, I would say, is endoscopic assisted that helps us identify potential residual. It's not something that I as a surgeon use, but there's a lot of surgeons who do use this technique. But definitely the anterior skull base within a window in the very front of the brain, extending back about 5 centimeters between the eyes, roughly in that area, we can resect endoscopically. Much of it comes down to the consistency of the tumor and the surgeon's comfort as well. I would say ultimately the surgeon's comfort is very important.
Thank you so much. I think we have time for just one last question. This question is asking, how does the risk of recurrence change depending on how much of the tumor was removed?
How much does yeah, that's a very good question. You know, this is an area that a number of centers are focusing on to answer. So I show, for example, results of methylation that we use at our institution. There are others who use copy number alteration, which is a more readily available test done within the pathology labs. Some of my colleagues use that as a mechanism with very good results. Collaborators of ours, my colleagues that do this. So I think when we look at, again, our larger cohort of tumors, and I showed you the methylation divides it into 2 or possibly more groups determining outcome. The extent of resection, which is what you're asking, how much of the tumor was left behind, seems to not be a dominant factor. It's a factor, but it's not a dominant factor. Ultimately, the biology of the tumor, whether it's methylation that we use or copy number alteration that other individuals at other centers use, or mutational burden is typically not what we use, but methylation or copy number, those factors ultimately override the extent of resection. Of course, it's important. However, it's not the determining factor. So I wouldn't really think of it as if you have residual for grade 2, therefore it's a must that it would come back. It ultimately, the biology of the tumor will determine its recurrence rate.
Thank you so much for that wonderful answer. Unfortunately, that is all the time that we have for questions. I just want to thank you again, Dr. Zadeh, for your wonderful presentation and for taking your time to share your insight and expertise with our audience. And a special
thank you very much.
Thank you. And a special thank you to each and every one of you, our attendees, for joining us online today and sharing your thoughtful questions. We hope that you found this webinar to be informative and beneficial. We encourage you to take a few minutes to complete our webinar survey by scanning the QR code shown on the screen here on your mobile device. You can also go to the link shared on the screen and also shared in the chat. Your feedback is important to us as we plan for future programs, so please do share your feedback. You will also receive a link to complete the survey and a follow-up email message over the next few days. Aside from our educational webinar series, the ABTA has a variety of programs that help support patients and caregivers throughout their experience. For more information about ABTA's programs, events, and services, Visit ABTA's website at abta.org, email us at info@abta.org, or call the ABTA care line at 1-800-886-2282.